Moving on to next session, since we are running a little late and we would like to wind up today on time, I would not take much. And it is an extension of what Mohammed Hisham was saying. He spoke about microbial stewardship, he spoke about antibiotics, the right use of antibiotics, and that is where our next session comes in. So it will be a plenary session in which the topic is combating antimicrobial resistance strategies for effective stewardship. And as a chair, I would like to invite Dr. Vikas Manchanda, who is Professor Microbiology and Infection Control Officer, Maulana Azad Medical College and Associated Hospitals. Sir, thank you so much, first of all, for coming second time and taking out time from your busy schedule, please. I would also like to invite none other than Dr. Sangeeta Sharma. She speaks so well. I would always had those memories. Last time we had last minute cancellations and I requested ma'am, and it was such an interesting session. Thank you ma'am. Despite your issues, your problems, you have taken out time and come over. Would like to have the privilege of calling upon Dr. Jatin Ahuja, who is infectious disease specialist, Indraprastha Apollo Hospital, Delhi. Dr. Himanshu Dewan, Group Director, Critical Care Medicine, Sarvodaya Hospital. May I have the privilege of calling upon Dr. Manisha Mendiratta, who is Associate Director and Head Pulmonology, Sarvodaya Hospital. And Dr. Shiwangi Sharma, Associate Consultant Microbiology, Sarvodaya Healthcare. Request Dr. Vikas Manchanda to please take over.
So, very good morning to all of you. So, the topic which is there in today's plenary is slightly deviating from the overall theme which is there, but it is very, very integral part of the patient safety, and to by large extent it's a community safety also and environmental safety also, right? So, before we start, how many of you have taken any antibiotic for any reason in last 1 year? Please raise your hands. So there is large number, and I can tell you from last 10 years, for the time I remember, I have not taken any antibiotic. The reason is that we do pop-up pills, these pills, whenever we have URI. Whenever we have some high-grade fever, whenever we have some tummy upset, it's typical of popping up something and going around. So, consumption of antibiotics, when we say, it's really high in community. And it is not only the humans who are consuming it, it's the animal health also, where it is used in cages and all, and the agriculture. So, all are contributing to the consumption of antibiotic and harming the environment. I always teach my undergraduate students, by saying we all are immersed in the world of bacteria. So this world belongs to bacteria, not to us. They came much before us on the earth. We invaded their land, right? And now the topic becomes the combat. That means you are fighting with them. Just imagine if you have to be in a combat mode with your neighbors, not only the neighboring countries but immediate neighbors. What will be the response? It will be coming up with more and more vengeance and harming you at all, So combat probably is not the right answer. It is to look into how we can live in harmony with them. Otherwise, the day is not very far when we don't have any antibiotics to care ourselves from the deadly diseases. Right? With this brief introduction about what we are going to have, I would like to move forward with the, can I go there? That would be better, I think. So we have the eminent panelist here. So this is the article which was just seen in the Economic Times a day before. A podcast which is saying India's dangerous misuse of antibiotics. So the topic is very, very, TRP catching article, topic is there. But the fact it is not the only India which has to be blamed. It's all global phenomena which is there. But definitely the threat of AMR crisis or antimicrobial crisis is real, So this is a data which has been presented or published, which says that the cost per patient of antibiotic resistance is to the tune of almost $20,000 or $25,000, which is there in one infection, right, in US. Of course, you can translate it in Indian setting, which may be slightly lower, but it is corresponding to the GDP which is there. It also says that US economy is losing almost 20 billion of healthcare costs and 35 billion in the year loss of productivity. So what does it mean is the cost of antimicrobial resistance is really immense to the country, to the hospital, to the patient, right? So it has impact. We all know it increases the mortality and morbidity, economic burden, impact to the food security also. We are also now having a new fashion of having antibiotic-free eggs, antibiotic-free milk and all, right? And now it is the public threat. So with that, we would like to start with our panel discussion. And I would request if any of the person in the audience have any subsequent question or the link question in hand, they can just interrupt us and can have the question, please. So what are the common mechanism of transfer of antimicrobial resistance? Because this is how it is being spreading a lot. Dr. Shiwangi, would you like to answer, please?
Good morning, everyone. It's a pleasure being here with the great dignitaries. I thank Sarvodaya Healthcare for the same. So coming on to the question, I'll put it as simply as possible. There is one organism and then there are neighboring organisms. Antimicrobial resistance is a change in the gene. Either the organism will mutate, it's trying to save itself from the drug that you are giving, or there will be a horizontal gene transfer. That can be anything from transduction, conjugation. You have your mobile genetic elements as simple as transposons. So anything is possible. And then once it is there, as commonly there, survival of the fittest. The moment you get the gene, it tries to multiply and give it to its neighboring elements. So that's how, as to put it simply, that's how a mutation occurs. It happens to the next organism, next to that one particular one that has been mutated. It will try to transfer and they will try to survive. It is as simple as that.
Yeah, thank you, Dr. Shivangi. So what is happening is, due to these genetic mechanisms, you pop up a pill which you think that is going to cure your respiratory infection, but is being taken in by your gut flora, right? The normal gut flora you are having, and they will also become resistant. Later on, they are the ones who are going to give you the infection with the more resistant bugs. This is how the resistance spread within the body, and as it moves out of the body, it is going to be into the environment and again affecting the community by large, right? Thank you, Dr. Shiwangi. So next question is to Dr. Himanshu. Can you please highlight what are the unique challenges you are facing related to AMR in your intensive care units now?
So good morning, everyone. It's always a pleasure to hear you, Dr. Manchanda.
Thank you.
So AMR, antimicrobial resistance, is one of the biggest challenges that we face as intensive care professionals in this country. So I normally say that whenever a patient comes to an ICU with an infection, we are mostly able to get him better with the infection he came with. When he has then several rounds more of infection which he succumbs to. So AMR is probably the biggest hurdle that is between him and going home that we face in this country. Now, why is this challenge so big for us? Number one is massive misuse of antibiotics on a community basis. By the time we get the patient into tertiary setups, the patient has already been exposed to antibiotics he should not have been, very high in antibiotics, and at times for non-infectious causes like viral infections. Dengue is on meropin. Then after he comes to the ICUs, we end up having a lot of invasive lines and other procedures, a tube in throat, a line in place, and that increases the risk of further infections. Now, you imagine this person who's come to the ICU doesn't have the best of the immunity, is probably immunocompromised. So a person who's already been exposed to high antibiotics, has invasive lines, and is kind of immunocompromised, and is surrounded by other patients cross-contaminated with high drug resistance organisms. So this is where the ambit comes that we face in an intensive care unit, and from this muddle, we need to get this patient out to recovery. So I think that is the biggest challenge we face for antimicrobial resistance in intensive care units for our country.
Yeah. So what it means is that the hospital flora is highly resistant. So an environment in which the patients are being treated, the bacteria lying there is highly resistant, is exposed to a lot of disinfectants and antibiotics. That burden is there. So if there is a cross transmission from there, it can lead to more problems for the patient than benefit to the patient. So that means infection prevention practices are of paramount importance, specifically in the intensive care units, right? So the next question is to Dr. Manisha. What is the impact of the same AMR when we talk about the respiratory infections?
So good morning all. So earlier the pneumonias were easy to be treated with simple guidelines, as we had specific antibiotics for community acquired pneumonias or hospital acquired pneumonias. But I think more than 50% of the patients don't respond to the antibiotics which are advised as first line antibiotics as per the guidelines, probably because of the resistance, and similarly the resistance because of the overuse of the antibiotics. At the tertiary care centers, when the patient presents to us with pneumonia, they have already been exposed to higher antibiotics. And at the end, if we go for the cultures, most of the time the cultures are resistant to the antibiotics. So it gets very difficult for us to use antibiotics as per guidelines, and the severity of the pneumonia becomes life-threatening.
Yeah. So the thing is, we need to remember, majority of the respiratory infections are viral in nature, right? So the bacterial pneumonias are very small subset of that. Of course, there are certain risk factors and certain subpopulation where bacterial pneumonias are going to be more often, which you can come across. The most common cause of bacterial pneumonia is the Streptococcus pneumoniae. Over a period of last 15 years, the pneumococcal resistance, which was negligible in India, has increased to almost 15 to 20%. So what does that mean? Almost quarter of your pneumonias need to be treated with higher group of antibiotics, specifically in a community setting. Right? So the next question is to Dr. Jatin. What is the impact of the AMR overall when we see around on the overall patient outcomes?
Very good morning to all the Sarvodaya family members, and thank you Dr. Manchanda for asking the question. Coming on to the clinical impact of AMR, first of all, there is always an increased morbidity. Patients who are coming with a disease has to be bombarded with multiple antibiotics, and there is an increased length of stay would be there. Then in the critical care, patient would be having the n number of devices, whether the C line, the A line, and intubation. All this will lead to the more chances of getting the infection, and that lead to the long length of stay. Then the burden on the patient pocket as well as the burden on the government settings also. So all this will have the morbidity impact. Then coming on to the mortality impact, the bugs which we are getting into our system, like they are the super bugs, that will have the impact in terms of the increased mortality also, in spite of the targeting with the higher to higher antibiotics, and patient will not going to survive. These are in terms of both morbidity as well as the mortality also. Another impact would be in terms of I would say lack of the good diagnostic services. The patients who are having the IgM typhoid positive, I will say a very common example, start on the higher to higher antibiotics, first monosef, not responding, azithromycin, then on the meropenem, without knowing that IgM typhoid has no relevance, and patient might be having some other disease. So there is a lack of clinical judgment from the, I would say, doctor side also. And then coming on to the patient side, the lack of awareness, eagerness to get relief of the treatment. Whether, as mentioned, that most of the respiratory infections are the viral. So even with the viral, people want the fever to go in the 1 day or 2 days. So in that context also, the bombarding of the multiple antibiotics is there.
Yeah. So what is happening is, more resistant drug means more time to treat it, and patient and doctor both are restless, right? So to enhance or to shorten the morbidity, they are pumping more antibiotics or higher range of antibiotics into the patients, leading to more and more resistance which is there. So it's a vicious cycle which is coming up, which is leading to more harm than good to the patient and to society. So there is longer treatment and worse outcome which are being seen around with the impact of AMR, right? Now talking about a bit of the antimicrobial therapy and challenges which are related to the AMR. What is the role of inappropriate use of antimicrobials as contributor of AMR? Dr. Shiwangi, would you like to answer this?
So I'll answer this with a very simple example, sir. There is a 60-year-old patient who gets viral diarrhea, and over the counter you just don't get ORS, you get antibiotics. So that patient starts taking antibiotic. Now what happens is the gut is already busy in fighting with the virus, and then there is the gut microbiota. That antibiotic will do something in the body. It is definitely not going to kill the virus, so it will act on your gut microbiota. Now the good biota will decrease. So now there is organisms which will start expressing the genes that are required, as I mentioned, for resistance. Once there is expression of gene, then there becomes a selective pressure. Matlab, it is trying to transfer that gene to its neighboring organisms. So ultimately, viral diarrhea, body will somehow, the patient will be cured of the viral diarrhea thinking that the antibiotics worked. But what will happen is that you have reduced your flora, the good bacteria, you have exposed your flora to a drug that was not required, and now you have the MDR organisms. So next time when that 60-year-old patient will have some other infection or some other issue, not even an infection, might land up in a hospital setting, he or she will be already harboring the MDR organisms. And once on ventilator or some other thing, anything for that matter, will end up with a very high drug resistant bacteria. And then we come back and think that ye kahan se aaya, infection control practices, site se transfer hua, but it is years and years of inappropriate antimicrobial use that we play havoc with our gut microbiota and our flora and give a chance to the organisms to develop these drug resistance mechanisms.
Yeah. So putting simply, reserve your antibiotics for your old age. Do not use antibiotics left and right. More you use antibiotic, more your flora will becoming resistant. So you need to reserve your antibiotic armamentarium and your bacteria, keep them in harmony with each other. Okay. So next question is, what is the importance of appropriate antibiotic use in the treatment of the respiratory infections? Dr. Manisha.
So, as you already mentioned that most of the respiratory infections are viral.
Yeah.
If we categorize patient in our OPDs, most of them are bronchial asthmas or COPDs. So, asthma exacerbations are supposed to be allergic. There is no infective organism involved in it. So, those patients otherwise also don't need antibiotics. These COPD patients do need antibiotics. We just recently did a study which showed that 70% of these COPD exacerbations which landed in the emergency, and we had sent the sputum culture on day 1, and we started antibiotics considering COPD to be an infective exacerbation. 70% of them were non-infective, and out of those 30%, 10% were already drug resistance, like drug resistance to the first line antibiotics. So we have to be very judicious in using antibiotics. And then important is, okay, the patients come to you with sepsis, pneumonia, septic shock, ARDS. We start higher antibiotics. The important point is to de-escalate the antibiotics when we receive the cultures. Even if we are not able to start lower antibiotics at the admission, we can always de-escalate antibiotics after 48 or 72 hours of cultures we get. That would definitely help us to save those antibiotics and make pneumonias less virulent for decades.
Yeah. So what is mean is that probably the community acquired infections or pneumonias need to be differentiated from the healthcare associated or the high risk group of people having pneumonia. Another is the patient subset. Those who are typically healthy and coming with pneumonia are more likely to respond with lower set of antibiotics than those who are having recurrent infection or have some underlying comorbidities which are leading to this kind of situations. Okay, so the next question is, what is the state of development and challenges of newer antibiotics, because we are finishing our armamentarium of antibiotics which are available in the country or globe by and large. Ma'am.
Yeah, thank you, Vikas. Good morning to everyone. Antibiotics have been the most important discovery of this century. If you read about pre-antibiotic era, you know how people were dying because of the infectious disease. The antibiotics coming with penicillin and later having a golden era with these subsequent classes of antibiotic coming in. We have had the golden era, and we thought that infections are no longer a problem now. But unfortunately, the harsh truth today is that we have added non-communicable diseases to this infection burden, and then accidents and other things to this burden. So we have a triple burden, and this non-communicable disease add to the infection burden. Diabetic patients, coronary artery patients, they are more susceptible to get these infections. So, but unfortunately, for last more than 2 decades, we haven't had any new antibiotics coming in. When I say there has been an innovation gap, no new antibiotic, I mean a class of antibiotic. You must be thinking that every day we keep hearing cephalosporin, first generation, second generation, now 5th generation cephalosporins are there. Similarly, but these are generations of these antibiotics. Pipeline for new class of antibiotics is running dry. Please remember this. We haven't had any new classes for last 2 decades. Now, why is it so? There are several reasons behind it. The basic principle, the discovery is basically looked after by the pharmaceutical industry. Return on investment is the basic, logic or the principle that they follow. The discovery process is a very long drawn, time intensive, effort intensive process. It takes 10 to 12 years to get a drug to the market. Involves billions of dollars during development. Now with the use of AI technology, artificial intelligence, though this period has been reduced, but then even if you find out a new drug, then you find that there are many regulatory challenges to get this approved, get to the market. So that is why pharmaceutical industry has taken them off from this class of group, because they know the very fact they don't get return of investment, because they know the moment few months after introduction of a drug in the market, within 6 months to 1 year they will start getting this AMR reported, because this is a natural biological phenomena. You cannot stop it. So this resistance has to develop. Misuse, overuse, underuse triggers it, accelerates this problem. So by 1 year, 2 years, the drug will be stopped you will not use, you will look for some other. Then third major reason that they don't get return on investment is that this is being introduced for a very select group of patients, which need, where the need is only for few days. But they get more return when they discover drugs for diabetes, cancer, where the treatment is lifelong. So don't depend on the pharmaceutical industry to take care of your problem, that they will come up with the new class and then you can manage. So if I have to talk about the numbers, WHO has recently released the report. There were total 32 drugs in the pipeline globally. Then out of that, only 12 qualified for certain phases of the clinical trial. And out of that, only 4 are likely to come into the market. Recently, yes, one drug discovered by Indian company, Orchid Pharma, enmetazobactam, they have introduced, this is the first drug of new class that has been approved by FDA also. But again, I keep my fingers crossed, because if we misuse, again, although this has a novel mechanism, this drug is targeting at the enzyme, not at the bacteria. So likelihood that this drug may work for a longer time, but you never know. Bacteria have always been smarter than us. Remember this. They have always remained one step ahead of us. They know how to survive even in the presence of these antibiotics. So we have to, as the Vikas puts it, we have to learn to live with them in harmony. So I think my take home is, don't depend on the new classes.
Right. So the question which always has arisen by the Darwin theory, who is more evolved, the bacteria or the humans, So the theory says, more you spend time on earth, more evolved you would be. So who is spending more time on earth? It is the bacteria. So they are much smarter, much more evolved than us, right? So they just need a single cell to make them survive, and their survival instinct is very, very strong, right? What does that mean is, you develop antibiotic over a period of a decade and they will take few days to finish it off, right? So new antimicrobial agents are difficult to develop and to sustain because of the various reasons as has been outlined. The next question is accepted that we are having limited antibiotics, accepted that we are in a world where AMR is a vogue, then what is the role of the existing antibiotics and how the jugglery goes on, right? So how the drug combination and adjuvant therapies or adjunctive therapies can help us in mitigating the AMR risk. Doctor?
I think it's for me only.
Yeah.
I think drug combinations, yes, we have very good combinations. For example, this augmentin, amoxicillin clavulanic acid, where the enzyme which neutralizes this drug, if you combine it, increases its efficacy. There are few known combinations like piperacillin, tazobactam, and then there are many more. But certainly, only select combinations work in synergism. Synergism, when I say, it means 1 + 1 is more than 2. If it is more than 2, then only you use it. But if it is just 1 + 1 makes it 0, that means, or negative, it is antagonism. 1 + 1, if it is just 2, just for sake of it, we combine, don't do that. Very commonly misused combination is ciprofloxacin with tinidazole. Several hundreds of combinations you will find. There are so many combinations of some of them are antagonistic. So please just don't go by. If somebody tells you that this is a new combination, you can use it. Please look into it whether it is a synergistic combination or not. So with word of caution, you should use. Now coming to the second part, adjunctive therapy. These are also equally important. important. Adjunctive therapies here could be probiotics, prebiotics, vaccines are very important. Somehow we are neglecting that part. Vaccination can reduce the number of infections. So number of opportunities for use of antibiotics are also less if the person is properly vaccinated. And then these phages, other things, delivery methods, there are these metals, these are being studied. But we haven't had a breakthrough, coming in, which can be readily used in practice. So, and third adjunctive could be, because no new class is coming, maybe we can think of repurposing of the existing medicines. If they have some antimicrobial activity, perhaps we can look at that.
Yeah. So we are in a world where cocktails are in vogue, Same is true in the treatment also. So Dr. Himanshu, how these cocktails or combination of antibiotics is helping, or what are the measurable elements for their successful de-escalation?
So I think a very relevant question for what we do on a daily basis. How do we tackle MDROs, multiple drug resistant organisms? So it doesn't mean that the moment you have an MDRO, go for the highest antibiotics. You have to first understand how that organism is creating a ruckus. So is it creating a ruckus because of the virulence or the resistance? And MDRO, it is mostly resistance and the virulence at the same time. Now here we might use a single good antibiotic or use combinations, depending on what resistance mechanism we're trying to tackle. The guidelines for critical care and sepsis per se have been off and on doing single antibiotic, dual antibiotic, single antibiotic, dual antibiotic for gram negatives. In our country, we deal more with gram negatives, less so with gram positives. So when you talk about gram negative MDRO organisms, we tend to use dual antibiotics in sick patients, and individual antibiotics has a different mechanism of action. So very important, you can't use two antibiotics which are targeting the same area on the bacteria. You always have combinations which target different areas, right? So in MDROs, for example, if you use an antibiotic which is ceftazidime avibactam with aztreonam, you try to do different area of enzymes to take care that the antibiotic works. Or you use colistin with meropenem, you're trying to save the effort that the colistin would put in to kill the bacteria. So these combinations are there. Then you have antibiotics like beta-lactams with aminoglycosides, and these combinations work on different areas of how the bacteria is going to create virulence. Now the other part of the question is that how do we successfully measure and de-escalate the antibiotics? Very, very important. I was listening to my fellow speakers, and respiratory infections, most of them are viral. When you look at OPD basis, when you come to ICU, a lot of them are bacterial. You can't afford to mix a bacterial infection, say, abhi main 3 din antibiotic nahi दूँ. Patient would be dead in 3 days. So you have to be careful that in the subset of severity, you may start with an antibiotic with a very clear declaration on day 1 that I'll stop the moment I think the patient is better or deemed non-infective. Very, very important. So de-escalation strategies are one of the best ways to save your antibiotics. So how you de-escalate? How do you stop the antibiotics? A lot of time what happens is you have cultures. If you have a culture positive, you are targeted, you complete 5 days, 6 days, 7 days of antibiotic, you stop it. What happens if your cultures are negative? How do you de-escalate? A lot of times consultants would say, no, I think cultures are negative in 30-40% of the patients. I think we should continue. Probably not the best strategy. If the cultures and the clinical data shows that the TLC is normal, the patient possibly has a viral infection like dengue, and then the cultures are negative, you should stop the antibiotics. Even in serious infections, bacterial serious infections, 3 to 5 days of antibiotics are good enough to treat the patient after the source control is done. In abdominal perforation, after surgery, the source control is done, 3 days of antibiotics or 4 days of antibiotics are good enough for clinical cure. And likewise, if you send a culture, you get it in 48, 72 hours, and the patient has received 3 days of antibiotics, and you think the chances of having a bacterial infection are less, please de-escalate. Blood cultures are one way. Procalcitonin My other samples based on PCR based methods are ways where you can objectively decide that the patient can go for de-escalation. And the fifth way, which is most commonly used, is my eminence. Is I think this is not infective, let's stop the antibiotics. This fifth way is not what we could use. We could probably use the objective ways of looking at de-escalation. Thank you.
Yeah. So we are running short of time. Just a quick things which I would like to put in which were there in the subsequent slides. So the problem is why antibiotics are being overprescribed by the physicians. It's not they want to. It is mainly the lack of diagnosis, right? So early diagnosis and having good diagnostic modalities is a major gap. As we go on, these diagnostic modalities, as they improve, the usage of antibiotics can become more and more prudent. So if you see, this is the publication, these are the publications from the last volume, which is recent volume in the November issue of the Journal of Clinical Microbiology, which is highlighting here that newer diagnostics is under, we are just pressing gas on to have early and more precise diagnosis so that we can have early and directed therapy to improve our patient outcomes, right? Also, as has been told, overuse of diagnostics is another challenge. The study which has been published which says if you have a positive blood culture in first instance, having repeat culture is of only value in certain circumstances, that is the infection with Staphylococcus aureus, then the yeast or the candida, and the patient on lines. These are the three conditions under which repeat culture is of any help. Primary culture, if it is culture negative, repeated culture is of no benefit and should not be the practice. So this is what can help you in prudent use of diagnostic, what we call it as diagnostic stewardship in the healthcare. So the take home message is the spread of AMR is like a silent pandemic. We had a silent pandemic of hepatitis B and HIV, which has been tackled to large extent because of the advent of antiviral agents and good diagnostic techniques. But AMR is a bit different and is a real threat. Diagnostic stewardship, as I told you, is an integral part of the antimicrobial stewardship. What we call in a common language is judicious use of antibiotic by the collaborative approach. A tailored antimicrobial therapy through collaborative effort is key to improve patient outcomes, and every person in healthcare and community has important role to play in containment of this AMR pandemic. With that, I would like to thank my panelists and the audience for their patient listening. Thank you.
Thank you so much, sir, and thank you to the esteemed panelists, speakers for this really thought-provoking session. I would now request Dr. Manchanda to felicitate our speakers. And may I request Dr. Manchanda to please come on the red line. And may I now request Dr. Sangeeta Sharma to please come forward. Bobby is very particular about photographs. May I now request Dr. Jatin Ahuja.
Professor Manchanda, I just wanted to say a word here. Good morning, sir. You mentioned that there was a deviation from the patient safety thing at the beginning of your talk. But then, knowingly, though we had a pre-conference workshop on antibiotic stewardship, and because of this abuse and it is compromising patient safety, so it is one of the most important topic I felt, and that's why we wanted you to again come back for the same session and the topic.
I think I might not have conveyed my thoughts correctly. In fact, the WHO theme for patient safety this year is antibiotic use, using them correctly. So it's not deviation in that sense, it's a deviation the way the topics are there, more of patient experience and those kind of stuff, So that way it is slightly deviated. It's more of clinical topic than the other ones.
Thank you so much.